The first one will be talking about the role of alpha-synuclein in the therapies that are being researched nowadays on removing alpha-synuclein from the brain and bodies of patients with Parkinson's, which I think is the route for curing Parkinson's, hopefully. And then the second part of my talk will be discussing COVID-19 and its significance in patients with Parkinson's. So many of you are familiar with this slide. So Parkinson's disease is a brain disorder, and a neurotransmitter called dopamine is deficient because the part of the brain called the substantia nigra, which is in the brainstem or in the midbrain, degenerates. And the usual causative agents or triggers for degeneration of the substantia nigra that we have thought of are pesticide exposure, heavy metals, and also certain genes can predispose to degeneration of the substantia nigra. Now, we are able to confirm the diagnosis of Parkinson's usually at post-mortem. And what do we find in the brains and bodies of patients with Parkinson's? So what we find is the so-called Lewy body. And then with further staining, especially a special stain called alpha-synuclein staining, we now know that the Lewy body consists of misfolded alpha-synuclein. Now, mind you, alpha-synuclein is not a bad protein. In fact, it is a normal protein which is present in neurons, in the brain cells. In fact, they estimate that alpha-synuclein maybe consists about 1% of the proteins in the neurons in one's brain. So we find the alpha-synuclein mainly in the axon terminals, but we also find it in the cell body right beneath the cell membrane. So we know that alpha-synuclein has certain important functions. So it modulates the stability of the membrane of the neurons. It also influences the signaling from one neuron to another. It also is involved in the trafficking of proteins and other substances across the axons. Now, how does a good protein that has a good function called alpha-synuclein become pathologic? So what happens in Parkinson's and these other synucleinopathies is that the native alpha-synuclein, which is a monomer or a helix, starts to clump and aggregate and forms oligomers, and then further clumps and aggregates forming protofibrils, and eventually the alpha-synuclein fibrils and bigger fibrils, and then eventually the Lewy bodies. So the native form of alpha-synuclein, which is unfolded, is not pathologic. It is only when it misfolds and then clumps together that it becomes pathologic. And there is evidence that the misfolded alpha-synuclein can actually infect other cells. And we have good evidence of that. In fact, in earlier studies of patients who've had cell transplants. So for instance, if these patients, when they pass on and their brains are analyzed, what they found is that the cell transplants from fetuses eventually get infected with alpha-synuclein as well. So we know that the alpha-synuclein, the misfolded alpha-synuclein, can be transmitted from one cell to another. And this is how it gets propagated. Now, what is the effect of misfolding of alpha-synuclein? So what happens is that it interferes with a number of things. So it interferes with transport of these important proteins that have to be transported from one neuron to another. It also promotes mitochondrial defects. So we know that the mitochondria is the powerhouse of the cell. It is the battery that powers the different functions of the cell. And it also fosters oxidative stress and accumulation of bad free radicals. So when oxidative stress levels are high and you accumulate these bad free radicals, what happens next is that cells die, and therefore what we see is that where we find this misfolded alpha synuclein in Lewy bodies, we also see evidence of cell death. And then the other piece of the equation is what causes misfolding of alpha synuclein. So it's for quite some time we've known that there's certain factors which foster or increase the incidence of Parkinson's, like for instance pesticide exposure or heavy metal exposure, like exposure to manganese or lead or mercury. So the so-called toxins lead to misfolding of the alpha synuclein, and also some genetic mutations. So there are at least 5 known mutations involving the alpha synuclein gene, and that any of these genetic mutations can cause the misfolding of this normal protein. And then once these proteins misfold, they form certain structures that we now recognize on pathology. So for Parkinson's, we look for the Lewy body, or we look for the Lewy neurites. And whereas for multiple system atrophy, we look for what's called cytoplasmic inclusion bodies, which are mostly present in the glial cells. So the glial cells are the support cells in the brain or in the spinal cord, and this is where we find the so-called cytoplasmic inclusion bodies, which are clumps of misfolded alpha synuclein. So the list of synucleinopathies is not a long one. So the most common synucleinopathy that we see in clinical practice is Parkinson's disease. I've alluded to the second most common one, which is multiple system atrophy, which is a combination or combination of Parkinsonism with ataxia, which means incoordination. They also have prominent autonomic symptoms, like for instance, orthostatic hypotension, incontinence, constipation, sweating abnormalities. And then the third most common synucleinopathy that we see is dementia with Lewy bodies. So dementia with Lewy bodies is a disorder that is a crossbreed between bad Parkinson's disease and bad Alzheimer's disease. And the hallmark of dementia with Lewy bodies is that the cognitive issues are very prominent and an early feature, and usually precede the onset of Parkinsonism. So Parkinson's disease patients and MSA patients, for instance, may develop some dementia, but usually the dementia is seen in later stages, not in the beginning. Whereas in patients with dementia with Lewy bodies, the dementia or cognitive impairment is seen very early on. The other hallmark of dementia with Lewy bodies is the presence of hallucinations, which are very prominent. And then when we give these patients the same drugs that we use for Parkinson's, most commonly levodopa, many of these patients hallucinate even more. And then there's a fourth disorder called pure autonomic failure. This is a rare disorder. It only presents with pure autonomic symptoms. There's no Parkinsonism, there's no tremor, there's no shuffling of gait. So they have very prominent orthostatic hypotension, urinary incontinence, possibly bowel incontinence or severe constipation. Now, of these synucleinopathies, the one that we diagnose the most and the most frequently is Parkinson's disease. And mind you, the pathology studies have shown that even among movement disorder specialists like myself, the accuracy is not very good. For instance, one study showed that only 53% of levodopa responsive Parkinsonian patients that we diagnose as Parkinson's within the first 5 years actually have a diagnosis of Parkinson's. And then another study showed that out of 100 Parkinson's patients, we only hit the diagnosis in about 3/4 of those. In other words, 25% of the time or 1/4 of the time, we are wrong. And that's not very comforting both to ourselves and into the patients. And then for the other synucleinopathies like multiple system atrophy and dementia with Lewy bodies, the accuracy is even less. And therefore, what that means is that we may be treating a patient for Parkinson's or MSA or dementia with Lewy bodies, and a good percentage of the time we are wrong, and therefore it is only on pathology that the diagnosis is actually clinched and confirmed. So Parkinson's disease presents with both motor and non-motor symptoms, and the diagnosis is often made when a motor symptom appears. So the first time that somebody suspects Parkinson's, one of your physicians, maybe your primary care physician, or maybe a neurologist or a movement disorder neurologist, may see a tremor, usually a rest tremor in one limb, may appreciate rigidity on exam, and then the most common feature that leads to a diagnosis of Parkinson's is bradykinesia, which means slowness of movements. And then the fourth motor feature, which is usually a later feature, is posture instability. So when I see posture instability in the early stages of a Parkinsonian syndrome, I usually doubt the diagnosis of Parkinson's, since this usually is a later feature. And then what's even more important is that patients with Parkinson's and other synucleinopathies actually present with non-motor symptoms as their initial presentations. So the way we look at this is that the motor symptoms will be the tip of the iceberg, and then you see this huge chunk of ice, beneath the water level that you don't see, that actually precede the so-called non-motor symptoms that precede the diagnosis by many years, as much as 20 years before the first motor symptom appears. So some of these very common non-motor symptoms that we hear about include impaired sense of smell or taste, REM behavior disorder, which is dream acting, mood changes, so they get more frequent anxiety and depression, some memory difficulties. Some of these patients, even from the get-go, when we diagnose it with Parkinson's, present with what's called mild cognitive impairment, sleep disturbance. Some patients have difficulty sleeping. If you do a formal sleep study on this patient, their sleep architecture is not perfect. And then many patients complain of fatigue. So in other words, what we usually diagnose as Parkinson's would be the so-called clinical Parkinson's, when in fact preceding the actual motor symptoms and recognition of Parkinson's, prior to that, there is this so-called premotor stage, and even before that, this so-called pre-symptomatic stage. And the pre-symptomatic stage or premotor stage comprise the so-called preclinical stage of Parkinson's, or prodromal Parkinson's. So, and this premotor stage can be as much as 10 to 20 years before the first motor symptom appears. But even before that, this pre-symptomatic stage, if you look at this dotted red line here, this is where the degeneration of the substantia nigra starts, and the eventual, progressive loss of dopaminergic cells in the substantia nigra appears. And by the time that the first motor symptom is appreciated, one would have lost at least maybe 50% of the dopamine producing cells in substantia nigra before the tremor appears, before the rigidity appears, before the slowness of movement, shuffling, and so on and so forth. So I just want you to be aware of the so-called premotor stage and pre-symptomatic stage of Parkinson's, which can comprise several decades before the diagnosis is actually made. Now, why is it important for us to establish the diagnosis even before the motor stage? Well, if we are more cognizant, especially as clinicians that make the diagnosis of the preclinical symptoms or the premotor symptoms of Parkinson's, then we can probably institute a few things that can potentially influence the progression of the disease or the appearance of the symptoms at some point. So for instance, instituting a lifestyle change. So instead of being sedentary, we'll probably say exercise more, eat healthy, load up on your antioxidants, more veggies, less of the dairy, more fruits, um, get better sleep. And then as far as the potential neuroprotective drugs are concerned, like for instance, there is some evidence that that some dopamine agonists or MAOB inhibitors like rasagiline or selegiline are possibly neuroprotective, can possibly alter the early stages of Parkinson's if given as early as possible. So if we are able to recognize the preclinical stages of Parkinson's or premotor stage, one can argue that maybe perhaps one can institute uh, therapy with one of these potentially neuroprotective drugs. But again, there's no studies yet on this set of drugs as being efficacious in the preclinical stages because, mind you, every study that we've done so far that is looking for cure for Parkinson's have recruited patients in the motor stage. So for instance, we say, okay, let's investigate this new drug that is an MAOB inhibitor, and we're are looking for patients with early Parkinson's. What we look for are the early motor symptoms of Parkinson's. We're not recruiting patients in the premotor stage or in the preclinical stage, and maybe we should be, because almost every drug, or should I say every drug that we've tried so far that look very promising in vivo studies or in animal studies, and that now we've tried to use in humans, all of these studies have failed in terms of bearing out as being neuroprotective or curative for Parkinson's. And maybe one of the reasons for that, or should I say the main reason for that, is that we are recruiting patients later in the stage of Parkinson's, in the so-called motor stage, when in fact we should be recruiting these patients in the earlier stages. So how can we possibly diagnose Parkinson's in the premotor or preclinical stages? So there's several ways that we can potentially do that. And I'm going to discuss each of these three bullet points here. So smell kits. So we know for a fact that patients with Parkinson's have impaired sense of smell. This can precede the diagnosis anywhere from a few years to 20 years before the first motor symptom appears. There's a certain kit that we use called the upsit. So I'm pretty sure you guys have some experience in buying products that you kind of scratch off first, and then you kind of sniff and say, okay, test it out and say, okay, this smells like whatever. And these are mainly utilized, for instance, for perfumes and things that are fragrant. So if you use the upset, you will be able to we will be able to test whether your sense of smell is impaired. However, this is not specific for Parkinson's. So there's other neurodegenerative disorders or genetic disorders or other causes for limitations of smell testing. For instance, this is also abnormal in Alzheimer's disease or Lou Gehrig's disease. I did an experiment I'd say about 30 years ago on X-linked dystonia Parkinsonism, which is LUBAG, and their sense of smell is also impaired. Some of the spinocerebellar ataxia syndromes also present with impaired smell. And of course, there's other reasons for your smell to be impaired, like for instance, nasal congestion, colds. This is very frequently seen among smokers, trauma to the nose, and so on and so forth. Okay, what about the DAT scan or the dopamine scan? So this is widely utilized now in the US and in many first world countries. This is the normal DAT scan in your left. So imagine your nose to be here, your ears to be here this side, and here is the back of your head. And deep inside your brain is the basal ganglia, and this is the normal dopamine signal. If you inject a tracer that tags the dopamine neurons. So it looks like a bean shape, two bean shaped structures here, or kidney shape or tadpole shape. You have a head, which is the caudate head, and then a tail, which is the putamen. So this is the normal DAT scan. And you see here in the right, the DAT scan of a patient with Parkinson's. So what goes first in Parkinson's patients would be the signal in the putamen or the tails. And this is quite quite distinct for Parkinson's patients, and usually starts more in one side first than the other. And usually in Parkinson's patients, we see this asymmetry very frequently. So one side tends to degenerate sooner than the other. So if somebody presents with Parkinson's disease, like a phenotype in my office, I do a DAT scan and I see the DAT scan being normal, then I kind of have to go back to the drawing boards and say, okay, it's not Parkinson's disease, it has to be something else. Or if I see somebody that, for instance, I diagnosed with essential tremor, has no obvious Parkinsonism yet, or maybe has a little bit, but is kind of elderly and not sure whether this tremor or the a little slowness or stoopness or posture is related to a Parkinsonian syndrome and not just to age. If I see this kind of DAT scan, I kind of say, okay, this patient with essential tremor must have Parkinson's at this stage. Okay, what are the limitations of the DAT scan? So first of all, it's not specific for Parkinson's disease. So there's other mimics, or should I say there are other diseases, I should say, where the DAT scan will be abnormal. Like for instance, multiple system atrophy, especially the Parkinsonian type, MSA-P, Parkinsonian type of MSA. And then progressive supranuclear palsy patients also often have abnormalities in their DAT scans. Patients with dementia with Lewy bodies, there was one study where almost all patients in their cohort present with abnormal DAT scans. And then corticobasal degeneration, which presents with dystonia in one limb, usually one upper limb. And they also have this apraxia of that limb, may also present with abnormal DAT scans. Strategic strokes can lead to abnormal DAT scans as well, and some genetic syndromes, including Lubag or X-linked dystonia Parkinsonism. The huge majority of my patients with Lubag have abnormal DAT scans, so it's not specific for Parkinson's. Secondly, it can be read as normal, especially in the early stages when the findings are very subtle. And when that happens, it can mislead the clinician into believing that the patient, if read normal, doesn't have Parkinson's, when in fact, some of these patients clinically have Parkinson's. They respond to levodopa and have a sustained response to levodopa. And if you were to repeat the DAT scan down the road, many of these patients eventually have abnormal DAT scans. And then the results can also be influenced by medicine that they take. For instance, antidepressants, dopamine blockers are the two biggest classes of drugs that can affect the results of the DAT scan. And then the biggest one in third world countries, this is or even in the US, is that it can be very costly if it's not covered by insurance. So for instance, in the US, the average price, if not covered by insurance, is somewhere in the range of $4,000 to $5,000. Okay, what about tissue biopsy? So there's several tissues, peripheral tissues, that one can biopsy to try to detect the misfolded alpha synuclein. So they've done, for instance, research studies on salivary gland biopsy. So you can biopsy the parotid gland here, which is in front and below your ear, or you can biopsy the submandibular glands, which are beneath your jaw. The problem with that is that this needs a certain expertise, experience. Sometimes we even use ultrasound, and that the yield, even for established Parkinson's patients, is somewhere in the range of about 75%. So in other words, if we do 100 biopsies, salivary gland biopsies, for patients that are that clinically have Parkinson's, have abnormal DAT scans, respond to levodopa, about 25% of these patients, or 25 patients, will have a negative salivary gland biopsy. What about intestinal biopsy? So again, this can be hit and miss. It really does not differentiate very well between Parkinson's disease and the other synucleinopathies. There are also cases where the intestinal biopsies are positive and yet the patients are completely normal. And this also needs special equipment and special expertise, and it's quite invasive. It's not a very pleasant procedure. Certainly, it's not a procedure that I would jump into readily, or any of my patients will gladly embrace if I were to say that a colonoscopy is necessary in order to establish a diagnosis. Now, more recently, though, we have now looked into skin biopsies, and alpha-synuclein is actually present in the skin of Parkinson's patients. For instance, if you do the alpha-synuclein stain, and this is the brain now, the red, the portions which are red here are the portions where alpha-synuclein is present. And if you do the same patient and do a skin biopsy, you will also detect alpha-synuclein. And therefore, skin biopsy now is one of the tools we use for detecting alpha-synuclein in the periphery, which correlates with having alpha-synuclein in the brain as well. It's minimally invasive. We use a very tiny tool that punches the skin. It is about 3 millimeters in width and about 4 or 5 millimeters in depth that we punch, and then we do 3 sites behind your neck, above the knee and above the ankle, and then there's no stitching required since the punches are so tiny that the punch hole closes on its own without any stitches or stitching unnecessary. And then we send the specimens to a lab, and the first lab, commercial lab, to do alpha-synuclein staining happens to be here in Phoenix. It's called the Cutaneous Neurodiagnostics lab. And then they send us a report. So what they do is, for instance, here's the skin biopsy specimen. What you see here in green are the autonomic neurons. I said the autonomic nerves, rather, peripheral nerves. And it stains the axons of these nerves. And then if you do the alpha-synuclein stain, what you will see is a positive overlap between the nerve fibers, autonomic nerve fibers, and the sites where alpha-synuclein is detected. So, for instance, this is a normal, healthy control. This is the skin biopsy. We're now looking at the autonomic nerves in the dermis. So you see that in green here. Then if you stain a normal, healthy control for alpha-synuclein, that same skin biopsy specimen is negative for alpha-synuclein. Whereas for Parkinson's patients, you see here the neurons, the nerve cells for the axons, and then the same axons or nerve cells are now positive for alpha-synuclein. Okay, so it is, we now know that alpha-synuclein is present in the skin of patients with Parkinson's disease. The levels of alpha-synuclein tend to be higher as the disease progresses. It also tends to be higher as the autonomic symptoms become more prominent, most commonly lightheadedness or orthostatic dizziness, as well as constipation. So what premotor symptom or non-motor symptom is most suggestive of a synucleinopathy? That symptom is dream acting or REM behavior disorder. So REM stands for rapid eye movement sleep. It is the deepest stages of sleep when one dreams. And the natural thing is for one to be paralyzed while you're dreaming. So all your muscles are paralyzed. So you don't move, you don't jump out of bed, you don't kick, you don't punch. Whereas patients with Parkinson's or REM behavior disorder often act out their dreams. And they found out that 94 to 98% of patients with RBD or REM behavior disorder are associated with a synucleinopathy. And in fact, RBD by itself is probably the premotor stage of one of these disorders, either Parkinson's, MSA, or dementia with Lewy bodies. So if a patient is confirmed with a sleep study to have RBD, or REM behavior disorder, what will happen down the road if we follow these patients longitudinally? Well, 50% of these patients will convert to a synucleinopathy in 12 to 14 years. In other words, they will convert to either Parkinson's disease, multiple system atrophy, dementia with Lewy bodies, or pure autonomic failure. And then about 75% of these patients will convert by 50 to 20 years. And some patients may have a latency of conversion as late as 50 years. And that may explain why some individuals who have adult onset or late onset REM behavior disorder never develop or will never have be diagnosed with Parkinson's or one of the synucleinopathies, because sometimes the latency of conversion can be as late as 50 years. Now, where does the misfolding of the alpha-synuclein first happen? Is it in the brain or is it elsewhere? And the answer is it happens first in the gut. So there is this brain-gut connection. The gut or the intestinal tract actually has its own nervous system, its own complex of nerves, autonomic nerves at the under the surface of the or under the mucosa all the way from the esophagus down to the rectum. There's this complex of nerves called the enteric nervous system, and so the misfolding of the alpha-synuclein actually starts here in the periphery. And eventually this misfolded alpha-synuclein will make it to the brain. And so that begs the question as to, how does the misfolded alpha-synuclein reach the brain? And there happens to be a conduit, a nerve, a very long nerve called the vagus nerve, which is in fact the longest cranial nerve, which goes all the way from the medulla, which is the lowest part of the brainstem, and all the way down to the rectum. And the vagus nerve is a very important nerve for many, many functions of critical organs and structures. So for instance, your heart, your lungs, your stomach, your small intestines, your large intestines, the liver, the pancreas, the kidneys. So all of this depend on the vagus nerve. And if we are saying that, or we think that misfolded alpha-synuclein first accumulates in the intestinal walls, well, with time, some of this misfolded alpha-synuclein will be able to make it up the vagus nerve and eventually make it to the medulla and eventually higher up to the midbrain where the substantia nigra is, and start the process of infecting more cells and eventually making it up to the higher parts of the brain and brainstem. Now, is there a way to reduce or get rid of this misfolded alpha-synuclein? So there's several approaches that are being studied at this point, and we're gonna try to discuss each of this briefly. So there's antibodies, for instance, that can be developed against alpha-synuclein. So for instance, if you do animal studies using mice, and if you were to inject the mice with misfolded alpha-synuclein, they will produce antibodies against this misfolded alpha-synuclein. And then these antibodies will now result in reduced burden of misfolded alpha-synuclein in the brain. So you can actually harvest these antibodies and introduce them into patients or animals with Parkinson's. So there's 2 phase 2 studies which are ongoing or have recently finished in the US, one by Biogen and Prothena. They both are phase 2 studies, and then there's phase 1 trials by 3 companies which are ongoing. The latest one that was reported is the Pasadena trial for a monoclonal antibody called prasinezumab. And this was a study of 316 Parkinson's patients. Unfortunately, they did not meet the primary objective, which is a change in their motor score. There's this there's this scale that we use to monitor the progression of Parkinson's called UPDRS, and that was the primary objective. However, there were improvements which are noted in secondary endpoints. It was very well tolerated, and I think the plan is to move forward with further studies using this this approach. And then Apheris has developed vaccine that they called PD01A, and this stimulates the immune system to produce its own antibodies against alpha synuclein. So there was a phase 1 trial of 24 early stage Parkinson's patients, and what they found out is that the vaccine resulted in production of alpha synuclein antibodies in half of these patients. However, they also noted that there was a decline of the antibody levels within a year, and therefore some of these patients needed a booster. So Apheris will be soon initiating phase 2 trials for this particular drug. And then United Neuroscience is conducting a phase 1 trial on UB312, again, another vaccine. This will be done, this study will be done in the Netherlands. Although the in vitro and in vivo mouse studies have shown that it promotes unclumping or disaggregation of the misfolded alpha synuclein. And then what about strategies to prevent the alpha synuclein from clumping together or aggregating? So there's at least 2 studies that are ongoing, one by Neuropore, which studies a drug called NPT200-11, and this binds to alpha synuclein and blocks its accumulation. And then there's this other drug called NPT088, which is being developed by Proclara. It's actually being studied for Alzheimer's as well as Parkinson's. It's supposed to bind to these proteins and prevent them from misfolding or clumping together. So these studies are ongoing for Alzheimer's, and if that is successful, the plan is to test this on Parkinson's patients as well. And then lastly, there's a few drugs which are actually out in the market already. They're not indicated for Parkinson's, but they're being repurposed because there is animal evidence or in vitro evidence that some of these drugs that we already have in the market may have properties of dissolving or scavenging alpha synuclein. Now, Ambroxol is a drug which is not available in the US. It is available in Europe and in Asia. It goes by the brand name most frequently of mucosolvan. What it does is it increases a certain enzyme called glucose cerebrosidase in the brain. And of note, about 10% of Parkinson's patients have a mutation in the GBA gene. Now, patients with Parkinson's with this mutation are usually a little bit younger and they have more cognitive impairment, but their motor or presentation or phenotype is exactly the same as Parkinson's. They're also levodopa responsive. They say that if one is positive for the GBA gene 1 mutation, one is at risk. One is more at risk for Parkinson's in the range of about 20 to 30 times more. They have found out that Ambroxol reduces the amount of alpha synuclein. So there was a study which was recently published called the AIM-PD study, and it used this amount of Ambroxol per day. It was a small study of 18 patients over 6 months, and what they found out was that there was improvement of the motor scores by on average 6.8 points. And then if they measured the alpha synuclein in the fluid in the back, the CSF fluid, they found that there was an increased level, which means, and they're interpreting it as alpha synuclein being expelled from the cells. And then there's this drug being used for leukemia. It's an FDA-approved drug in the US. Earlier studies showed that it may reverse a loss of dopamine neurons in animal studies and improve motor scores. And they think the way it works is that it dissolves alpha synuclein or removes them from the tissues. And then there was an open label study in 2016 for 12 Parkinson's patients with dementia as well as dementia with Lewy bodies. And they used 2 kinds of doses, 150 versus 300. And they found out that their motor scores are improved as well as their mental scores or cognitive scores. However, a bigger study was done, which was eventually published in December, and what they found was that the 75 patients given either 150 milligrams, 300 milligrams of nilotinib versus placebo. What they found was that the nilotinib group remained stable with no decline in motor and non-motor scores, and that there was 20% less alpha-synuclein and 30% less tau in those that received nilotinib. The biggest downfall, though, is that it is quite a toxic drug. It actually blocks a very important enzyme called ABL tyrosine kinase, which is crucial for cell function. So it's not an innocuous drug, and that the side effects are probably going to be the main limiting thing for a wide use in Parkinson's patients. And then there's this diabetes drug called Exenatide. It is a GLP agonist. It's used for diabetes. There was a phase 2 trial in 2017, which ran for 48 weeks for 62 Parkinson's patients. And what they found was that their motor scores improved, whereas those with that received placebo worsened. So this is going to be a trial that is going to now enter phase 3. It is ongoing in many states, including Arizona, including my center. They are planning on recruiting 200 patients, and this will run for 2 years. And again, they think that Exenatide may reduce the amount of misfolded alpha-synuclein in the brains and tissues of patients with Parkinson's, and hopefully reverse Parkinson's. And then can diet modify alpha-synuclein levels? And I'm glad that Vanessa and Teresa, talked about this also in their talks. So there's evidence of flavonoids being effective or being neuroprotective potentially. It can also be associated with a lower incidence of dementia. And in fact, there's this Chinese herb called bakeline, which was noted in vitro studies to inhibit fibril formation or dissolve alpha-synuclein fibrils. So can what you eat influence misfolding of alpha-synuclein? And the answer is absolutely yes. And again, Vanessa and Teresa touched on this. But as far as Parkinson's is concerned, the bad things that they mentioned in their talk have been touted also to increase misfolded alpha-synuclein in your gut. So processed food, pesticide-treated fruits and vegetables or produce, excessive sugars, preservatives, polyglycerol, lecithin, and heavy metals. Unfortunately, some of these we really have poor control over, like for instance, water, source of water, especially if you're drinking city water. Although manganese seems to be more commonly seen in water sources in farms, so deep wells and so on and so forth. And then these food items can also alter your gut flora, and certain things we consume, including drugs, can do that as well. And the altered gut flora can also foster misfolding. Okay.